Now I'd like to introduce Patricia Andre, and she's going to be talking about using surrogate markers of disease progression to improve clinical management of patients with ALS. Patricia.
Good afternoon. Thank you. I really appreciate the honor of being able to speak today about this work. Surrogate measures of disease progression are commonly used in ALS clinical trials. Measures such as changes in strength, vital capacity, and functional rating scales are oftentimes used in outcome measures for our clinical trials, but very little is known about using these surrogate measures in guiding clinical management of our patients with ALS. So today I'd like to introduce an innovative approach to improve our ability to provide proactive rehab care. It's based really on two premises. The first is that decline of strength is predictable for each patient during the active phase of ALS. And the second premise is that changes in functional ability occur when threshold strength levels are reached. So as rehab therapists and nurses in our ALS clinics, it's our job to plan ahead so that we can make sure that our patients have optimal functional independence. As our patients progress through their disease, it's our job to make sure that they have the equipment they need, that we provide equipment such as AFOs, canes, walkers, wheelchairs, Hoyer lift, so that our patients can maintain safe, independent mobility. So the question really is, how can we better predict the future needs of our ALS patients? We only see our patients in clinic periodically, maybe once every 2, 3, or 4 months. So using rating scales for individual patients is not linear. Rating scales such as manual muscle testing or functional rating scales like the ALSFRS is not sensitive enough to detect early disease. These scales use ordinal or ranking scales so that the steps between the grades are not always even. And so if you look at an individual's patient's progression using a scale, a rating scale, it can look like the patient might have a long plateau or have very steep drop-offs. Rating scales, however, are used very successfully in large groups of data in clinical trials. But for individual patients, they're not all that informative because of the lack of sensitivity. Using quantitative strength measurement, we have found that it is a very sensitive measure of disease progression. It correlates very highly with motor neuron loss, and strength changes in a very linear manner for each patient during the active part of the disease. And you can really see early change using quantitative strength measurement even before a patient might notice any changes in strength themselves. So strength measurement is very important for looking at individual patients. However, we know that ALS is a very heterogeneous disease. Some patients survive only several months, while other patients survive 10, 15 years or more. So it's very important to look at the individual patients. Certain ways that we have used in the past to look at quantitative strength testing in ALS. Here in the States, we used a strain gauge in a protocol called the TQ&E in the 80s and 90s. It measured 20 muscle groups using a strain gauge that was secured to an upright. It required the use of an entire room. The patient had to undergo a lot of position changes, and it was expensive. About 10 years ago, the Northeast ALS Consortium here in the States moved to handheld dynamometry, which is much more convenient and inexpensive. It does not require position changes. However, it relies on the strength of the evaluator, which is sometimes problematic when you're testing very large muscle groups. So at Mass General, we developed a new device to test isometric strength called ATLAS, or Accurate Test of Limb Isometric Strength. This has the advantage of not requiring any position changes for the patient, but the load cell is fixed, and it requires no strength of the evaluator doing the testing. So I had mentioned that strength loss is very predictable during the active portion of the disease, and here's just an example of that. We looked at strength, taking raw strength of 6 different muscle groups in the leg, knee flexion and extension in the right and left, and dorsiflexion bilaterally. Then we changed the raw data, or converted the raw data to percent of predicted normal based on the patient's gender, age, height, and weight. And this way we can really compare strength between patients. So if you look at this graph and you look at the patient's decline over a period of about 15 months, this patient is losing strength at a rate of about 42% of their expected strength per year. Again, to emphasize that this disease is very heterogeneous, that the patient in black is progressing very, very slowly and losing only about 10% of his expected strength in that year, whereas the patient in pink is progressing at a rate of 87% per year. So this has vast implications in clinical trials as well as our clinical management of these patients. So the question is, if we can predict linear decline of our patients using isometric strength testing, how many data points do we really need to be confident that we actually can predict that strength loss accurately? We took a large data set from Tufts Medical Center, about 4,500 patient visits, and we found that we need about 5 data points or 6 months worth of data in order to be able to accurately predict that patient's decline of strength over time. And this is by region. So we use the arm strength and the leg strength. And as we know, ALS is a regional disease. So looking at a patient's decline in strength for the arm or the leg separately, we could look at 5 data points or 6 months and be able to, with pretty good accuracy, be able to tell how fast that patient's progressing. And this really has a lot of implications in terms of clinical management. ALS, unlike other neurologic diseases like Parkinson's disease or MS, which have exacerbations or remissions, is not the case. ALS, if you're progressing very slowly in the beginning of the disease, you will quite likely progress very slowly throughout the entire disease. So it gives us opportunities for clinical management in terms of individualizing that patient's management. So how much strength is needed to perform specific functional tasks? Is there a threshold of strength that's needed to require certain assistive devices, to know when a patient may need a wheelchair and become non-ambulatory, when a patient may need assistance with eating or need BiPAP? So we can use normalized strength data to begin to answer some of these questions. And we looked at a large database from the Northeast ALS Consortium to try to answer these questions. We did find that the correlation between strength and function using the ALSFRS was fairly high. We also did some exploratory logistic regression work on this. But today, for the purpose of our presentation today, I'm going to be looking at data in a little bit simpler terms. We took the Celebrex data that contained about 1,700 patient visits, and we looked at each visit that was graded a 4 for walking, meaning walking was graded normally. And we looked at the strength for each of those patients, and it was 77%. So on average, patients who were graded as a 4 had 77% of their normal expected strength. Patients who were graded a 3 had about 59%. Patients who were graded as a 2 had 38%, and so on. And just to give a demonstration of this on an individual patient, this is a graph of a patient's strength decline on the left-hand side, on the scale on the left-hand side, over time superimposed on their ALSFRS walking item. And so you can see on the right-hand side is the ALSFRS score. As you can see, the patient is declining in strength significantly while walking is still being graded as a 4 or normal. And you can see that the drop-off in strength occurs precipitously and unpredictably. There's large plateaus between changes in strength grades. Likewise, we looked at arm strength versus the ALSFRS cutting food item, and we came up with similar results. Patients who were graded as normal in cutting their food and eating had about a 70% predicted normal strength, and et cetera. Again, looking at an individual patient, we could see this patient in arm strength is declining very linearly, while there's a large plateau in the ALSFRS score. We looked at all the different gross motor and fine motor items in the ALSFRS compared to how those patients graded out in terms of expected strength. And you can see that patients going from a 4, which is normal, to a 3, which is with some problems, the difference between a 4 and a 3 usually occurred somewhere around 65%. Again, looking at functional changes, we'd be looking at the differences from moving from one grade in the ALSFRS to the next grade down. So it appears that there is a functional cliff. For those of you in the States, where cliff is a pretty common term these days. But we all know that our patients seem to do well functionally, and then all of a sudden they seem to change a lot. In their ability to walk, patients normally usually report that they're walking normally until they lose about 1/3 of their expected strength. And they need assistance to walk by the time they lose about half their strength and become non-ambulatory by the time they lose about 20% of their strength. Patients usually require assistance with fine motor tasks once they lose about 50% of their strength, and they're dependent by the time they lose about 75% of their strength. Patients report difficulty with shortness of breath with activity or lying flat by the time their FVC reaches about 50%, and we know it's a practice parameter to provide BiPAP by the time a patient reaches that level. Patients usually need continuous ventilatory support by the time they reach about 25% of their expected vital capacity. But we know that these rules are not hard and fast, and there's a lot of room for interpretation and variance. One of the big factors that will very significantly affect these readings or these predictions is spasticity. We know that our patients who have significant spasticity do much worse clinically, much worse functionally. So if a patient just has pure weakness, they can retain their ability to walk much longer than a patient who has a lot of spasticity. So this is a real wild card in doing these types of predictions. Also, demographics such as age and pre-existing conditions really can make a difference and may change these predictions significantly. Other things that really make a difference are the regional onset and spread of the disease of ALS, because we're looking at arm strength in general bilaterally and leg strength in general bilaterally. The usual spread of ALS is thought to go from one side to the other very quickly, but in some patients we know it stays on the unilateral side. So the patient might have a great deal of weakness in one leg, but not in the other, in one arm and not the other. So that will impact this ability to make these types of predictions. So if we take this one step further and we want to look at what's this patient going to look like further out and we say, gee, when is this patient going to be dependent in ADLs and perhaps need somebody to be with them all the time, we could actually mathematically look at about when this patient would drop to the point where they'd be dependent in their ADLs. This is not cut in stone, and as I said, there's a lot of room for interpretation, and a lot of things can make these numbers different. But it does give us a guidance in terms of what we can do. So using projected strength change for clinical management, I think we all should anticipate that patients will start needing equipment once they drop below 70% of their expected strength. And most importantly, the greatest functional decline occurs between 65% and 30% of their expected strength. This is the time we need to see them in clinic more often. So we really need to see patients in clinic more often during the middle of their disease, and if they're declining faster, we need to see them more often. Future work is needed to collect better data clinically and to regularly measure strength in our patients, and then develop practice guidelines based on this evidence, and to really individualize patient management. All patients are not the same. And I'd like to thank everyone who supported this work, ALSA, ALS Therapy Alliance, and especially thank my mentors, Dr. Ted Munsat, who really pioneered quantitative testing, and Dr. Mirasakovic for supporting this work. Thank you.
Any questions? While the microphone's getting there, I noticed the laughter at the functional cliff, but I'd have to say ALS is a financial cliff for all of us, certainly for patients.
Pat, thank you so much. It was a wonderful presentation, and my question is actually related to if most of your patients presented with limb onset, or if you also were looking at patients that presented with bulbar onset. And if the device that you created is something that can be used for those with respiratory or bulbar symptoms as well, or if it's primarily related to the limbs.
We looked at patients who had onset, both limb onset and bulbar onset. However, looking at the active phase of the disease means that you can only predict how a patient is progressing if that patient is losing strength. So, for example, of a bulbar onset patient who has no limb strength loss, this would not be valid. So you have to see loss in order to say that the patient's in the active phase of the disease in that region. And also, after the patient drops and loses 90% of their strength, then that curve really flattens out tremendously. So it's really not very informative to collect data after patients lost 90% of their strength.
Any other questions? Last chance? Well, join with me in thanking Patricia.